Good morning, everybody. Thanks so much for joining me today. This is Sandy Atkinson. I am a clinical quality consultant with the Iowa Healthcare Collaborative and have been with the organization for about 7 months now. Prior to that, I was the Director of Quality and Patient Experience at a critical access hospital. So I look forward to learning from everybody today. Just a couple of housekeeping items. Please mute your phone lines, otherwise you will hear an echo if you're listening through the computer and vice versa. Don't place the call on hold, because then I'll be able to hear your music, as will the other attendees. Please utilize the chat box for questions, and this session is being recorded. So thanks so much today. So this first webinar series is going to cover ventilator-associated events. The whole series is part of the hospital-acquired infections superset. So the first 2 weeks of this Jumpstart series is going to be ventilator-associated events. The second 2 weeks is going to cover C. diff, and the last 2 weeks will cover post-operative sepsis and sepsis. So I look forward to hearing from all of you today. Just so I know, can you tell me who is in the room and what organization you're with? And then just to get to know you a little bit better, what is your most favorite thing about fall? Okay, so I've got some things coming in about fall, pumpkin spice, football, bonfires, and watching the leaves change. And I would have to say, I think we're really starting to hit the height of leaf change here in Iowa. They're a beautiful red and golden color. So thanks so much. All right, we will go ahead and get started. Our objectives today include to increase the awareness of identifying and reporting all ventilator-associated events, utilizing root cause analysis tools to assess ventilator-associated event practices, define and utilize best practices for process improvement, and then create peer-to-peer collaboration among hospitals. So I would like to hear from listeners, how do you identify ventilator-associated events? Do you have a specific tool built within your electronic health record? Do you have a paper tool? How do you all handle that? I know from past experience, at least from me anyway, most of the time it's been built within the electronic health record. And it's usually the larger hospitals, of course, that utilize the vents. Most critical access hospitals have ventilators, but primarily for transportation purposes to transfer patients out. Patients who have a requirement to be on mechanical ventilation for any length of time are usually going to be at the larger tertiary facilities. I believe with most electronic health record components today that there is some type of algorithm that is built into the electronic health record to capture the important pieces for when patients are mechanically ventilated. Just interested to know if any of you have champions within your facilities to monitor and track either on a daily or weekly basis for making sure that those components are met. Some folks are using the NHSN calculator to plug in by reviewing the vent days and then complete the daily ICU rounding. What is involved in your daily ICU rounding, out of curiosity? What do you look for those types of patients? Identifying who is on a vent and are the vent bundles ordered. That's a great way to start your investigative process if you ever do end up with an event, is by going back to essentially square one and ensuring that the bundle was adhered to from the start. We're going to move on and talk a little bit about ventilator-associated event definition and the scope. There are typically two subsets that are included when you're talking about ventilator-associated events. The CDC identifies a ventilator-associated event as a patient who's been on a ventilator for upwards of 2 calendar days and were stable, and then there was a change in either oxygen status or a destabilization of the patient. So ventilator-associated events are typically characterized by a combination of objective criteria that include a deterioration of respiratory status after a period of stability or improvement on a ventilator, evidence of infection or inflammation, and laboratory evidence of respiratory infection. The baseline period is defined as the 2 calendar days immediately preceding the first day of increased daily minimum PEEP, positive expiratory end pressure, or FiO2, which is forced inspiratory oxygen. They go on to classify, and it didn't used to be this way. So everybody, when they initially started monitoring for ventilator-associated pneumonia, everybody came to the table back in 2013, 2014 and said, you know, this is such a broad definition for ventilator-associated pneumonia that they determined that they needed to categorize it just a little bit further. And so they've got a couple of subsets out here where it's ventilator-associated conditions such as fluid overload, atelectasis, and or ARDS, ARDS, or acute respiratory distress syndrome. And those are typically caused by the treatment modalities that patients go through when they are mechanically intubated. It could be that they've had tremendous amounts of fluids because they've suffered sepsis or some type of a trauma, or they have an underlying condition, perhaps, that may have caused trauma to the lung tissue itself. So the other piece that CDC hones in on and talks about is infection-related ventilator-associated conditions, or IVACs, and that includes pneumonia or potentially sepsis can develop from that as well. For those of you that report to NHSN, what are your thoughts about the algorithm that NHSN has out there for reporting? Do you feel that it gives you a good breakout of identifying whether it's a VAC, an IVAC, or potentially a PVAP? I've gone through and perused the algorithm that NHSN has, and I agree. I think it does a great job of identifying and helping to ascertain exactly what type of event you're potentially dealing with. Why are VAEs important? It's because it has a huge impact for those facilities that do intubate and keep mechanically ventilated patients for any length of time. You'll see that it impacts nearly 800,000 hospitalized patients a year, and 5 to 10% of those ventilated patients will experience a ventilator-associated event. The cost is an additional $41,000 with an additional increased length of stay up to 14 days. And so I don't think with that information that we can deny that these are extremely important to get ahead of and prevent rather than react to. Moving on, ventilator-associated pneumonia is considered one of the most lethal healthcare-associated conditions. And again, talking about the impact to our healthcare system, the mortality rate is 35% for ventilated patients. 24% of the age group 15 to 19 years old could potentially die when they're ventilated, and then it's 60% for age group 85 or older. And I would have to say I think those are the two most significant groups that are impacted by this outside of pediatrics. For this topic, I just wanted to primarily focus on young adults and adults primarily for the topic. Short-term morbidity concerns when it comes to ventilator-associated events include ventilator-associated pneumonia, sepsis, acute respiratory distress syndrome, pulmonary embolism, barotrauma, pulmonary edema, along with the increase in healthcare costs and the increase in length of stay. Anybody who's worked in ICU, CCU, and or trauma understands that the sooner we can get patients off of mechanical ventilation, the better it is for them from a short-term and a long-term effect. Long-term morbidity concerns when it comes to mechanical ventilation is that they have slower overall recovery time. It takes a long time when you've had a machine doing your breathing for you to try and get back to a normal baseline, and sometimes patients are not even able to reach their normal baseline. Occasionally, it can leave debilitating physical disabilities. They may continue to have problems with aeration in their lungs. They may have problems with the barotrauma from having a ET tube placed for a long amount of time. The piece about the cognitive dysfunction lingering, it's hard when you've got patients who are typically in an ICU, CCU setting. They are not stimulated to the point, and especially when they're mechanically ventilated and they're on drips for pain medication and or sedation and any other number of IV medications they can receive. It does a number on their cognitive status. It can create psychiatric issues, anxiety, depression, or post-traumatic stress disorder. You know, a lot of times patients who have been intubated will have rememberings, if you will, about what it's like to be intubated. They didn't like it. You know, the fact that they could look at people, but they couldn't talk, or they were breathing around the air tube. It's quite disconcerting for patients when they're placed on mechanical ventilation. So with that being said, there are some components of a care bundle that facilities can use to prevent ventilator-associated events. You know, it can include care of the head of bed, so ensuring that the patient's head of the bed is at 30 to 45 degrees. Performing oral care minimally every 4 hours. I've seen some literature recently that's talking about doing oral care every 2 hours. I'd be interested to know in what our facilities are doing. Are they using the 4-hour time frame, or are they considering moving to the 2-hour time frame? Subglottic suction for the endotracheal tube, pulling out those secretions so they don't pool for those patients. And then using a lower tidal volume when it comes to mechanically ventilated the patient, 6 to 8 milliliters per kilogram of delivered tidal volume or less. There's been some studies that have been done through the Critical Care Association and Trauma Surgeons Society, where they feel that having a lower tidal volume for patients is much more beneficial and a good prevention of ARDS for these patients. And then also implementing the ABCDES Bundle elements. So let's talk about these just a little more in depth. Thanks, Lana. I agree with you. I see moving to more every 2 hours of oral care as being based on best evidence. I agree with that. Everything that I've been able to come across has indicated that, but there are still some facilities that aren't ready to graduate to that level yet. I've also seen the use of CHG mouthwash when they're doing oral cares on patients as being extremely beneficial in the prevention of infections. Moving on, we'll talk about the head of the bed. So I would be interested to know if in your order sets that the facilities use, do they have something in there that speaks to the head of the bed? And if they've identified that as a issue for them, have they included or thought about doing visual cues on the walls, such as putting tape? You know, do any of you have a champion that goes around and assesses ventilated patients and their head of bed elevation at each shift? Or do you have a process for head of bed elevation in non-ICU areas, such as transport? I can tell you that many times I have talked to critical care nurses and or respiratory therapy staff, and they have patients who are doing very well, especially when I was in the case management role, patients who are doing very well in the unit, and then they either have to go to imaging for a CT scan or perhaps an MRI, and the patient is remaining ventilated, and then they come back and the patient has had a back step because they had to lay flat for a certain length of time rather than having their head of bed elevated. So talking about some of those types of things to prevent events from occurring is something to consider in your order sets. And then finally, do your order sets include head of bed elevation checks? You know, do you have somebody on your unit who goes around and checks those as a quick look-see, whether it be perhaps the nursing supervisor or the unit director, or is it something that, excuse me, that the, you know, the ward clerk could potentially see from the desk where they're located? The next area to focus on is subglottic secretions drainage. So, you know, are you using an ETT tube that allows for easy suctioning of those secretions? Do you have protocols for regular oral care? You know, as we discussed, is it every 4 hours? Is it every 2 hours? And how do you ensure that's being completed? You know, do you have a checklist that goes through and is required to have documentation? Is that one of those hard stops for nurses in the unit, whether it be ICU or CCU, where they can't progress to complete their nursing documentation until they've checked that off? And then I'd be interested to know how many of you are using a CHG mouthwash. I know when I did some orientation and some rounding in ICU, this has been many years ago, they were still using sterile saline for secretion suctioning. And they were doing it roughly every 4 to 6 hours at that time. But I'd be interested to know how many are doing CHG as a mouthwash. And then with your CHG mouthwash, do you brush teeth Do you use just a soft, gentle toothbrush, or do you use the little mouth swabs to go in and clean the patient's teeth every couple of hours? Those are considered best practices to prevent ventilator-associated events. And then low tidal volume ventilation. This is gaining more traction in the evidence-based world, in that if patients are on low volume tidal ventilation, try and say that 3 times fast, or sometimes it's noted as low tidal ventilation volume, they're seeing better results with patients in that they're not having as many ventilator-associated events, but they're also finding that they're able to take them off the ventilator sooner and begin the weaning process. They've found in several studies that they have less potential for trauma and really do much better post-ventilation than patients who tend to have a higher volume. It also is good to prevent ARDS for those patients that have the structural lung issues. So just a couple questions for you all to think about, and I'd love to have you weigh in on what your thoughts are. How often do you assess tidal volume? Is it assessed every 4 hours? Is it assessed every 12 hours at shift change? Is it assessed every 24? Just type into the chat box and let me know what your comments are. You know, and the other thing that I would like to know is it something that's a standing order, perhaps, that's managed either by the physician in conjunction with parameters set for nursing staff, or is it all RT based? You know, does respiratory therapy have the capability to make those adjustments based on patient outcome in collaboration with the provider? The other thing that I would like to know, and these may be questions that we bring up next week to talk about, is do you have an interdisciplinary team that reviews all ventilated patients daily? I know from past experience that typically for teaching hospitals anyway, they would make rounds in both the trauma unit, in ICU and CCU for the residents to get experience, but then also it would give them exposure to ventilators and help to cement their knowledge base with it. So, yeah, you're absolutely right, Lana. Standard order sets for RT are typically the norm. I agree with that. I know in some of the very large facilities, it's typically ARNPs can assist with that, or clinical nurse specialists as well. But most of my experience has been with respiratory therapy managing those pieces. So let's go into the ABCDES Bundle and talk about that just a little bit. That is an evidence-based practice by the American College of Surgeons, which handles trauma. It also talks about how the Critical Care Nursing Association has defined this and stood behind it. It's got several components that talk about it, and typically what I have found is that the order sets that are built within the electronic health record cover these pieces as well. But I did just want to touch on them because there are some components in here that either don't get enough attention or are glossed over. And so we'll talk about those. So for the ABCDES Bundle, A stands for assess, prevent, and manage pain. B is both spontaneous awakening trials and spontaneous breathing trials. C is the choice of analgesia and sedation. D covers delirium monitoring and management. E is early progressive mobilization and ambulation. And F is family engagement and empowerment. So this is where your PFE and or your PFAC, Patient Family Advisory Council, comes into play. So let's talk about the assessment piece. With the assessment piece, it talks about the PAD guidelines. And for those of you that haven't heard about that, it is pain, agitation, and delirium. It identifies that pain control is a risk factor for healthcare-associated infections, and that a patient that is mechanically ventilated longer may precipitate delirium. And it's because they get used to, or I should say they're not used to all the noises and the bells, and you know, patients don't sleep when they're in the hospital, regardless of whether they're sedated or not sedated. And so it's really very hard to orient those patients when they're in the ICU. I know from past experience, nurses are very good to say, you know, even if it's 3 o'clock in the morning, do you know what day it is? Do you know who the president is? You know, and then they try very hard to keep those sleep cycles for patients. But the delirium, along with the medication that they have on board, can sometimes precipitate that confusion for them. So the guidelines for PAD, if you will, state that pain is routinely monitored in all adult ICU patients. You know, and again, some ICUs do this every 2, some do this every 4, some do this every 6. It just depends on the patient condition and the status of that patient. And vital signs alone should not be used for pain assessment, you know, because when you're dealing with somebody who's ventilated, you know, it used to be the old trade line that, oh, well, if their pulse is elevated or if their respirators are elevated, then they're having pain. Well, that may be true, but they may have a very high pain threshold. So, you know, it may be that you're giving them too much sedation and they're not able to be as active, if you will, than they would without the sedation. And then IV opioids may be the first line of choice for non-neuropathic pain in critically ill patients. So the neuropathic pain can sometimes be very hard. So with this one, you're talking more along the lines of trauma. So those you know, head injuries perhaps, or those patients that have had lengthy surgeries after trauma. You know, I can think of open book fractures for pelvic patients, that kind of thing. B comes down to spontaneous awakening and breathing trials. So sedation in a mechanically ventilated patient may be necessary to control anxiety and manage their oxygenation needs. You know, many times when you are trying to get patients more active, but providers try to cut back on the level of pain medication that a patient has. And having worked surgery, I've seen how bones and muscles and tendons and things move, and there is a significant reason why those patients hurt after surgery. So sedation may be necessary in order to keep them comfortable. But the problem with sedation when it comes to mechanical ventilation is that it can prolong it. And so you run a very fine line of trying to define how much sedation do you give this patient to keep them comfortable and yet not lose their drive to breathe and keep them potentially as interactive as possible. Some organizations, and in the studies that I read, have talked about doing a daily sedation interruption, for specific patients once they've met a certain baseline, and decreasing their level of sedation so that they can potentially communicate and they can move their eyes and they can move their hands. Again, you run the fine line of how much sedation do you give somebody so as not to snow them, but to make them cognizant and alert. And then sedation can sometimes mask those patients who are having neurological issues. It's challenging to try and perform a neurological assessment on somebody who's had sedation to ascertain whether they're at baseline or returning to baseline or not even near baseline. So it can be difficult when it comes to neurological assessment. And then daily screening of respiratory function using awakening and spontaneous breathing can reduce the duration of mechanical ventilation and risk of ventilator-associated pneumonia. I know, having worked with several ICU nurses for years, they really did not like having patients on ventilators, and they were constantly pushing providers to try and get patients off of ventilation. And I think we're getting to a point now where patients are ventilated only if there's no other option. If you can't use a CPAP or if you can't use a BiPAP. I think we're getting better about not just throwing somebody on ventilation, mechanical ventilation to protect their airway, because we do have other alternatives now. And then designate a time of day that will not interrupt sleep cycles. Back when I was a little girl, I will tell you a story. My father was in the ICU for a heart condition, and I remember my mother saying that they would come in at 1 o'clock in the morning and try and wake him up, and get him to talk to them and that type of thing. And I always thought that was kind of odd. It's kind of like in the nursery when they go to give babies their bath at 3 o'clock in the morning. We need to try and keep to their sleep cycles as much as possible, and not disrupt those. That helps with the delirium as well. So, Lana, you made a comment about delirium in the ICU being so common, and that it's often challenging for teens to care for. And you're right, analgesia and sedation may be necessary to keep those patients in their normal wake and sleep time frames. I do agree with that. Choice of analgesia and sedation. Sedation should be goal-oriented, and typically when you're using sedation for patients, I have used the Richmond Agitation Sedation Scale, and I've also used the Sedation Agitation Scale. And those are both great scales in that they talk about, what do you want to accomplish with your patient that's on sedation? Are you still wanting them to be responsive? Are you still wanting them to be able to follow commands with their hands? Are you wanting them to, interact with staff as much as possible? Again, it's a fine line when you're dealing with sedation with ICU patients, because you never quite know if you're starting to see some agitation. Are you dealing with worsening condition? Are you dealing with lack of pain medication? Are you dealing with, irritation from having an ET tube in? Knock on wood, I've not ever had to have an ET tube. They just, to me, look like they are the most uncomfortable thing in the world. I can associate it with a Foley catheter, and I can tell you I didn't like that either. So I can imagine patients who are in an ICU not feeling well, that they really do need some sedation to make them comfortable. The Richmond Agitation Sedation Scale is a scale that's used to determine if a patient is sedated enough. The scale ranges anywhere from a -3 to a 0, which is really where you want patients to be at. Patients who score on the RASS of 2 or 4, 2 to 4, I should say, are not sedated enough and really should be reassessed for pain, anxiety, and delirium. And then when it comes to sedation, you really want to titrate to a light level of sedation. Again, you want the patient to be as interactive as possible based on what their condition is. There's some studies out there that are now talking about the use of benzodiazepine sedation as strategies, and actually prefer the use of non-benzodiazepines because they do not interact as much with sedation and pain medications. It seems like with benzodiazepine medication, used for anxiety and or agitation, that tends to augment, if you will, the pain medication that a patient is on. And so trying to stay away from those non-benzodiazepines is probably the best practice that you can have. And then analgesia as the first sedation should be used, rather than just jumping to, say, Ativan or some type of antipsychotic, using analgesia first, because if you can alleviate that pain in that patient, you're also going to reduce their anxiety and you're going to reduce their agitation. So trying a pain medication first as opposed to adding in, antipsychotics or anti-anxiolytics are going to be your best plan first. Delirium monitoring and management. Many times it remains undetected by nurses and doctors in greater than 65% of ICU patients. It typically is associated with an increased duration of mechanical ventilation, increased morbidity and mortality, and increased length of stay. Patients should be routinely monitored using, some type of scale. The couple that I have on here are the CAM ICU or the Intensive Care Delirium Screening Checklist. And we have information out on our website that talk about assessing ICU delirium and assessing delirium in patients and the impact that it can have on their overall goals of care. Certainly promoting early mobilization of adult ICU patients if it's feasible. I'd be interested to know how many of our ICUs here in Iowa do this. Do they get patients up and get them moving and try and get them weaned off the ventilator as soon as possible? I'd like to hear from some facilities on how they were able to implement that and move that forward. And then again, the use of non-benzodiazepine sedation when possible. So trying to avoid adding that extra layer of sedation to those patients is definitely beneficial. And then moving on to early progressive mobilization and ambulation, it impairs patients' ability to move and be active and get back to their baseline of activity if they've been mechanically ventilated and had to lay flat or had to be bedbound for any length of time. I know for myself anyway, if I've been sick for any length of time for 2 or 3 days, it's hard after I've been laying down or resting for a couple of days. I just don't have the energy or the strength, and it takes me a couple weeks to rebound. So I can only imagine what it's like for patients that have been mechanically ventilated. Weakness can impair ventilator weaning. It's hard when you've got patients who've been ventilated for a very long time to try and get their lung function back to where it was. You know, many times they have to go to pulmonary rehab after they've been mechanically ventilated for a long period of time to try and get their lung function back. Some are able to recover it and some aren't. It just depends on how long they've been ventilated and what their condition was to bring on the mechanical ventilation. Some risks that are associated with mechanical ventilation, you know, we've touched on ventilator-associated pneumonia. It can also bring on hospital-acquired pneumonia. It, of course, increases length of stay. It can cause skin breakdown. I don't know about you, but I took care of several patients who had been in the ICU mechanically ventilated and had skin breakdown on their neck. You know, it's that device-associated skin breakdown that was talked about in our pressure ulcer series, and how those can really impact patients. You know, their little cheeks can get very reddened and sore and abraded, and their neck, if they've had to have ties around their neck for ventilation and different things like that. So it can really cause a lot of skin breakdown, and then, you know, it's another reservoir for potential sepsis. And then the delirium incidence, and then decreased cardiovascular function. You know, patients who are mechanically ventilated, yes, it's all a synchronized dance, if you will, using the mechanical ventilator and then, you know, ensuring that their cardiac output remains intact, but they're not having that exercise-induced type of effect on the heart, and so it can weaken the heart muscle if they're ventilated for a long time. Family engagement and empowerment. And oh my gosh, you know, the PFE, the patient's family, and how well nursing staff communicate with the family truly is a benefit to the patient. And it helps bring the family involved in taking care of the patient as well. You know, I can tell you, I have seen ICU nurses, CCU nurses, trauma nurses talk to families, and they explain to them about mechanical ventilation. They explain to them the things that they need to look for if it appears as though the patient is struggling. It opens that two-way communication and allows for a just great opportunity for an experience that is both beneficial to the patient, the family, and the hospital nursing staff. It can also support the clinical care team. You know, one of my best experiences was when my husband was in the hospital, was having a great connection with the nursing staff and being able to communicate with them and know that I was supporting them. You know, they would hear me re-instruct my husband on things when they were taking care of him, and they knew that I got it. They knew that I was part of the care team with him. But I also appreciated the fact that they had enough trust in me to know that I would carry through with what their expectations were as well. Enlisting family members to provide reminders for daily cares. I don't know if any of you have been in ICUs lately, but that staff is tasked with a lot. You know, they may have 2, potentially 3 patients, but they are all heavy care patients, and typically they're ventilated and they're on multiple drips, and they have multiple lines going in, and they have to draw labs and different things like that. So, you know, it's good to partner with the care staff and let them know that, you know, hey, I'm here to be an extra set of eyes, an extra set of ears for you, but just know that if I haven't seen you do the mouth cares on my loved one within a couple hours, I'm probably going to say something. You know, and again, it's all about delivery. It's all about partnering and just knowing that you want the best for your loved one as much as they want the best for your loved one. You know, and then engaging family members to report things about, you know, whether they're seeing increased agitation with their loved one. I took care of a patient one time who really would not identify if they were in pain or not by using the pain scale, but the wife told me that if I ever saw the patient rubbing their hand on their leg in a circle for any length of time, that was typically how they indicated they had pain. They wanted to be very stoic and wanted to power through, if you will, on their own, but that was the only way that she could pick up on when this individual was having pain. And so I was very appreciative of with her sharing that. Thanks, Lana. I agree with you. You know, the current best practice is to move the device slightly to prevent the device pressure ulcer injury. With every oral care, I agree with that. And, you know, I think families can help with those pieces as well. They can help identify, you know, whether they've seen the ET tube moved, or they can help identify if the patient's been repositioned. So again, engaging your family members is a great way to get started. So what can you do? And how do you get started? You know, first piece is that you need to look at what your data shows. What are you seeing in Ventilator Associated Events? And then are you doing a root cause analysis when you're looking at those? Are you looking at, you know, the head of the bed? Are you identifying if the patient's having a routine spontaneous awakening trial? Are you ensuring that the ET tube has been moved, or that the device has been moved to prevent those potential device-related pressure ulcers? And then if you haven't began with a bundle, or if you don't have a bundle developed, you know, talk to your staff, talk to your providers, potentially talk to patients and their families and say, you know, what is your most important goal of care at this point? And then try and work at your bundle from that aspect. You want a bundle element, if you will, that's easy to trial, that has significant impact, and is likely to be successful. You know, the best way to do that is using the PDSA, Plan, Do, Study, Act, and then don't reinvent the wheel. There are a lot of facilities that use ventilators in the state of Iowa. Reach out to them, you know, the Critical Care Association, the American College of Surgeons. We have multiple resources for you to pull from and get started with. Contact your clinical quality consultant. We have a lot of resources available here at the HIIN as well, and we can get you started in those pieces. Barriers and challenges that you may run into is, you know, check in with frontline staff regarding the outliers in the bundle compliance. You know, ask your frontline staff, what is it about this bundle that's hard to accomplish? Or ask your frontline staff, how do you want to start this bundle? What do you perceive as the most important piece to start with? You know, compare your policy and procedure to your practice. Does it match? And if it doesn't, why? Identify what those outliers are, and then try and bring them together where they're complementary of each other. And then look to see if you can identify a provider, perhaps a nurse, or a respiratory therapist that can champion this area for you. You know, are there people out there that are just very passionate about this and have witnessed the good outcomes versus the poor outcomes, and really want to take this on and make it a concerted effort for your organization? And then define the responsibility of all aspects of the ventilator bundle. You know, is it all RT that's going to be responsible for these pieces? Is it going to be split between nursing and RT? Is there components that are provider-driven as opposed to nursing and respiratory therapy? Only you folks that deal with ventilators on a daily basis can make those types of decisions. But it's important to bring all of your stakeholders to the table and define what your goal is, and then start looking at what those pieces are that you want to implement. Well, that finishes my talk. And so we've got a minute or two for questions or commentary. I'd like to just see if anybody has any ideas or suggestions for facilities that are perhaps struggling, or just any commentary of good practices that they utilize. I'll have you just type those comments into the chat box here. Okay, well, not seeing any comments, we'll move on. We're getting close to the end of our time here. In the slides that we'll send out, there is a resource list on there for all of the topics that we talked about today. Next week, we will continue our discussion of ventilator-associated events. What I would really like to hear from is, or hear about, I should say, is assessment findings. What have our facilities identified in their review of policy, procedures, and practice? Are there specific barriers that are included or that they are challenged with trying to overcome? And then interventions that they're using to overcome those challenges. Sharing and collaboration between facilities, and then how do you define improvement outside of a decrease in ventilator-associated events? Are there other ways that you define improvement within your unit? So the last comment that I want to leave you with is, and to think about for next week when we reconvene, is if I was new to a unit that utilized ventilators, and you were trying to prevent ventilator-associated events, what is the most important piece that you would tell me? And it doesn't just have to be one, it can be several, but I just want to know what types of information you're sharing with those new staff members that have never been involved with ventilators before. So with that, I am going to end our talk today. I want to thank you all so much for participating. If you didn't get the slides, let myself or Lexi know, and we will get those sent out to you. As indicated, this is being recorded, and the recording will be up in a few days for you to listen to. Thanks so much for participating.